Good evening, everyone. Today is our fifth webinar. Today is our fifth webinar. Before introduction of our speaker, that I would like to give microphone to our Wayaba faculty batch representative. He has a message to you. Yeah. After that, I introduce the speaker.
Good evening, everyone. On behalf of the Faculty of Medicine, Wayaba University of Sri Lanka, I have a kind reminder. In order for us to complete the future webinars and carry out future sessions, we are sharing a link with a Google form attached, which includes a feedback regarding the sessions that has already happened. That was 4 sessions which occurred over the last 4 days. It would be a great help if you would kindly fill out these forms, a single form. The form has already been shared among the batch representatives of each of the faculties, and the link will also be shared in the chat today. So once again, I would like to remind, it would be a great help, as it would be quite helpful in order to get a feedback and know what changes has to be made in order to carry out future sessions. Once again, thank you.
Okay, thank you. Today our speaker is Dr. Anuradha Jayathilake. He's a hepatobiliary interest surgeon, that means a general surgeon with a special interest in hepatobiliary. He graduated from University of Kelaniya. After that, he did his MD from Colombo and he did his overseas training in Australia. Currently, he's working as a senior lecturer as well as general surgeon and with his special interest in hepatobiliary surgery. He's a very good teacher. I think he's an ideal person to discuss topic related to this hepatobiliary surgery. Today is an interactive session. Therefore, one student will present student will discuss a case with the consultant. Okay, now we can start the session, right? Okay.
Thank you, Dr. Dixon. So, who's the volunteer? Please switch on the camera and the microphone.
Good evening, sir.
Good evening. What's your name?
My name is Binu Gunasekara. I'm from the second batch of Wayaba University.
Okay. So, so you know about the final MBBS exam format, right? Am I correct?
Yes.
Yeah. So, when you consider the long cases, so we do have not like earlier. Now it's we do have observer history taking and the discussion in the separate 2 panels, right? Each panel contain 2 examiners, right? In the observer history taking, what you need to do is you need to get the history. So we give you 10 minutes and another 5 minutes for the examination. So I thought of just asking to present, not just ask to present the your case. So I will be the patient, right? And you need to get the history from me, right? Okay. Hereafter, I'm the patient, maybe up to 10 to, so you can get even 15 minutes for by now, right? Okay. Are you ready?
Yes, sir.
Okay. Right.
So may I speak in Sinhala or English?
So I think no one from Jaffna faculty, I suppose, right? So should be able to deal with the Sinhala. So most of the patients in other than the Jaffna and Medical faculties, so you need to communicate with the Sinhala most of the time, 99% time, even more than that. So it's better to get it from the Sinhala. Okay?
Yes, sir. Suba
So
Sandhyaවක්.
I'm a male patient, right? Okay? Okay.
Suba Sandhyaවක්. මේ මට මහත්තයාගේ නම කියනවද?
මම ඇවිල්ලා ජයසුන්දර.
හරි. වයස කීයද?
වයස 58යි.
හරි. ගෙවල් කොහෙද?
ගෙවල් ගල් නෑව.
මහත්තයා රස්සාවක් කරනවද?
රස්සාව කියන්නේ මම ගොවිතැන් කරනවා. ඊට අමතරව පොඩි කඩයක් තියෙනවා.
හරි. එතකොට මහත්තයා මේ සැරේ ඉස්පිරිතාලේ ආවේ මොනවා වෙලාද?
මේ සැරේ ආවේ නම් මට පරීක්ෂණයක් කරන්න කියලා ආවේ.
ඔව්. ඒ කියන්නේ පරීක්ෂණය කරන්න කියන්නේ කලින් ඉස්පිරිතාලේ නතර වෙලා හිටියද?
ඔව් මම කලින් හිටියා ડોක්ටර්.
ඒ නතර වෙලා හිටියේ මොනවා වෙලාද?
මට පොඩ්ඩක් කෑම කන්න අප්‍රියාව පොඩ්ඩක් ඇඟට අමාරු ගතිය වගේ තිබුණා. පොඩ්ඩක්
ආ,
ඇඟ කසන ගතිය වගේ පොඩ්ඩක් තිබුණා.
හරි. මේ ප්‍රශ්න මේ කොච්චර කල් තිබ්බද? ඒ කියන්නේ ගිය සැරේ ඉස්පිරිතාලේ නතර වෙන්න කලින්?
ගිය සැරේ දැන් සති 3කට 4කට විතර කලින් මම නතර වුණේ.
අහහ.
දැන් ඔක්කොම මාස 2කමාරක් වගේ ડોක්ටර්.
දැන් ඔක්කොම මාස 2කමාරක්. එතකොට මාසයක් මේ ප්‍රශ්නත් එක්ක මහත්තයා ගෙදර හිටියා.
මාසයක් විතර හිටියා.
හරි. වෙන මොනවත් ප්‍රශ්න තිබ්බද මේ කාලය ඇතුළත? කසන එකයි කැම රුචිය අඩු වෙලා තියෙන එකයිට අමතරව?
දැන් මුත්‍රා නිකන් තද පාටට වගේ ගියා.
අහහ.
ඊට පස්සේ අපේ වයිෆ් කිව්වා මේ කියන්නේ නෝනා කිව්වා මගේ ඇස් කහ වෙලා වගේ තියෙන කියලා.
ඒ කියන්නේ ඒක ගොඩක් කහ වෙලාද නැත්නම් සාමාන්‍යයෙන් මේ බය වෙන තරමට කහ වෙලාද නැත්නම් සාමාන්‍ය මට්ටමට කහ වෙලා වගේ කියලා
එහෙම
කිව්වා.
බය වුණාද නැද්ද කියන්න නම් දන්නේ නැහැ. මේ කහ වෙලා කියලා කිව්වා ડોක්ටර්.
ඒකින්ද ඉස්පිරිතාලේ ආවා.
ඔව් ඔව්. ඒ කියන්නේ ඔව්. ඒ හින්දා තමයි ඇත්තටම.
ඒත් එක්කම බඩේ කැක්කුමක් තිබ්බද?
බඩේ නිකන් අර එම තද බල කැක්කුමක් නැහැ. උනාට පොඩි අපහසු ගතියක් තිබුණා. කාලෙකින් නම් ඒක නම්.
ඒ කියන්නේ කොච්චර කල් ඒ කැක්කුම තිබ්බද?
මාස 4-5ක් තිබුණා.
කොයි හරි වගේද කැක්කුම සාමාන්‍යයෙන්
බඩේ මැද හරි උඩයි මැදයි වගේ.
වගේ. හරි. එතකොට මේ ඒ කැක්කුම කොහෙටවත් පැතිරෙනවද? කොන්දේට වගේ යනවද?
පොඩි කොන්දේ කැක්කුමක් නම් තියෙනවා ડોක්ටර්.
ඒක මාස 4ක් තිස්සේ ඉඳන් තියෙනවා. ඒත් එක්කම වමන යන ගතියක් වගේ තියෙනවද?
නෑ වමනේ නම් තියෙන්නේ නෑ ડોක්ටර්.
ඔච්චරයට වගේ එනවා උගුරට එනවා ගතිය.
ඒ කියන්නේ කෑම ගන්න අපිරියයි. කන්න හිතෙන්නෙම නෑ. ඒක නම් තිබුණා මාස 2කමාරක විතර.
එතකොට ඒත් එක්කම උණ ගතියක් තිබ්බද මහත්තයාට?
උණ හෙම්බිරිසාව හැදුනහම වගේ නම් හැදෙනවා.
ඔව් එහෙම නෙමෙයි. ඉස්පිරිතාලේ නතර වෙලා ඉන්න කාලේ තද උණ ගතියක් වෙවුලලා උණ ගන්න ගතියක්.
නෑ ડોක්ටර් නෑ.
එහෙම තිබ්බේ
නෑ.
එතකොට මේ කහ වෙන ගතිය, ඇඟ කසන ගතිය, මුත්‍රා තද පාටට යන ගතිය මීට කලින් මහත්තයාට හැදිලා තියෙනවද? ඒ කියන්නේ මේ මාස 3 විටින් විට කහ පාට වෙන ගතියක් වගේ එහෙම
අවුරුදු 20කට විතර කලින් අර හෙපටයිටිස් කියලා මොනවද අන්න ඒ අමාරුව හැදිලා නම් ඇස් කහ වෙලා හිටියා.
ඒ අවුරුදු 20කට කලින්.
ඔව් අර කෑම මේ මොනවද ඒ අපේ පැත්තටම හැදුනා ඒක.
හරි. ඊට අමතරව දැන් මේ මාස 3-4 ඇතුළත මේ විටින් විට කහ පාට වෙනවා සාමාන්‍ය විදිහට මේ ඇඟ කසන ගතිය වැඩි වෙනවා අඩු වෙනවා මුත්‍රා තද පාටට යනවා අඩු වෙනවා එහෙම ගතියක් නැහැ නේද?
නෑ ડોක්ටර් පටන් ගත්ත දවසේ ඉඳන්ම තියෙනවා ඒක.
එක දිගටම තියෙනවා.
දැන් අර මුත්‍රාවල පාට නම් ඉස්පිරිතාලේ ආවට පස්සේ පොඩ්ඩක් අඩු වුණා සේලයින් එහෙම දුන්නාට පස්සේ.
හරි. එතකොට මේ දැන් ඔයාලට තිබ්බ ප්‍රශ්න ඒ කාලේ මාසය ඇතුළත වැඩි වුණාද? කහ පාට වෙන ගතිය වැඩි වෙනවා, කසන ගතිය වැඩි වෙනවා.
කහ පාට වෙන ගතිය නම් එහෙම මට වැඩි වෙන එක නම් තේරුනේ නෑ. ඒ කියන්නේ අර කසන ගතිය බෙහෙත් දුන්නාට පස්සේ අඩු වුණා. බෙහෙත බිව්වේ නැත්තම් එනවා කසන ගතිය.
හරි. එතකොට මීට කලින් එහෙම වෙලා නතර වෙලා මොනවත් වෙලා නැහැ. හරි. ඒත් එක්කම කෑම මේ රුචිය අඩු වෙලා තියෙනවා කියවනේ.
දැන් නම් හැබැයි දැන් මොකුත්ම එහෙම කෑම කන්න අප්‍රියාව වෙරෙන්න එහෙම කහන ගතිය නම් නෑ දැන්. කහන ගතියක් නෑ මුත්‍රාවල දැන් නම් පාට හොඳයි ડોක්ටර්.
හරි. ඒ ඉස්පිරිතාලේ හිටියට පස්සේනේ අපි ඒක ගැන කතා කරා. හරි. ඒත් එක්කම බර අඩු වෙලා තියෙනවා එහෙම ගතියක් තියෙනවද?
අවස්වර බර අඩු වුණා හොඳටම. මේ ෂර්ට් උත් පොඩි වෙන ලොකු වෙන ගානට අඩු වුණා.
ඒ කියන්නේ ඔව් පැහැදිලි බර අඩුවීමක් තියෙනවා.
ගොඩක් අඩු වුණා.
කිලෝ ගානෙන් බර මයින්ඩ් නැතුව ඇති.
මං හිතන්නේ කිලෝ 10 15ක් අඩු වෙන්නේ නැති.
ඒ මාස 4
හරියටම
5
බැලුවේ නෑ ડોක්ටර් ඉතින්.
ඔව්
කලින් බැර බැලුවේ නෑ. දැන් නම් ඔන්න 50ක් විතර තමයි තියෙන්නේ.
හරි ඒත් එක්කම මේ කැස්ස හෙම්බිරිස්සාව නිතර හතිය ගතියක් එහෙම තියෙනවද?
එහෙම නෑ ડોක්ටර්.
ෆිට් එක කලන්ත
ඒ කියන්නේ මට
කැරගෙන
පොඩා අමාරු ගතිය නම් තියෙනවා ඉතින්. අසනීපයි දැන් වැඩක් කරන්න බෑ. මහන්සි
වස්වරවල
එහෙම
උණ
නම්
වගේ
තියෙනවා.
එහෙම
උණ
ගන්න
ගතියට
තෙහෙට්ටු
වැඩිය අමාරු තෙහෙට්ටු ගතිය තියෙනවා.
වගේ හවස් වෙනකොට නේද?
ආ.
එතකොට මේ කැස්ස හෙම්බිරිස්සාව හතිය එහෙම ගතියක් නැහැ.
නෑ.
හරි. ෆිට් එක හැදිලා තියෙනවද මේ ළඟදී? එහෙම නැහැ.
එහෙම නෑ.
හරි. පොඩ්ඩක් ආපු හැටියෙම ඉක්මනින් බඩ පිරෙන ගතිය තියෙනවා කිව්වා නේද? හරි. টয়ලට් යන
ඒ කියන්නේ කන්න අප්පිරියයි.
අපිරියයි.
අප්පිරියයි.
টয়ලට් යන විදිහේ වෙනසක් තියෙනවද?
ටොයිලට් දැන් නම් එහෙම ලොකු අවුලක් නෑ. ඒ දවස්වල නම් පොඩ්ඩක් අර නිකන් මේ පාට අඩුවට වගේ ගියේ. සුදු
ඔව්.
නිකන්
සුදු
ක්‍රීමැටි
පාට
වගේ
වගේ
නිකන්.
නේද?
ඔව්.
ඔව් ඒ කියන්නේ මේ තෙල් වගේ টয়ලට් එක මේ
එහෙම ලොකුවට තෙල් ගතියක් නම් තිබුණේ නෑ ડોක්ටර්. පාට නම් අඩුයි හැබැයි.
මැටි පාටට වගේද?
ඔව් ඔව්.
හරි. ඊට අමතරව තද කළු පාටට යන ගතියක් තිබ්බද? ටිකක් සෙවල වගේ
එහෙම
ගොඩක්
තිබුණේ
ගඳයි.
නෑ. එහෙම තිබුණේ නෑ.
හරි. එතකොට හරි. ඒත් එක්කම මහත්තයාට මේ වෙන බෙහෙත් ගන්න අසනීප තියෙනවද?
වෙන මට ප්‍රෙෂර් එකයි අර කොලෙස්ටරෝල් දෙමනවද තියෙනවා.
ප්‍රෙෂර් එක තියෙනවා,
ඔව්.
කොලෙස්ටරෝල්
ඒකට බෙහෙත් ගන්නවා ડોක්ටර්. ගමේ ડોක්ටර්ගෙන් ගන්නවා.
හරි. ඊට අමතරව ආයුර්වේද බෙහෙත් පාවිච්චි කරලා තියෙනවද? පාවිච්චි කරනවද?
එහෙම නෑ.
හරි. ඇදුම වගේ තියෙනවද?
ඇදුම නම් නෑ.
හරි. වකුගඩු ප්‍රශ්නත් නෑ නේද?
නෑ.
හරි. එතකොට කලින් ඔපරේෂන් මොනවත් කරලා තියෙනවද?
මගේ අර කැමරා දාලා මොකද්ද ඔපරේෂන් එකක් කරා මොකද්ද?
ඒක මේ ඉස්පිරිතාලේ නතර වෙලා හිටපු මේ
ඔව්
දවස්
නතර වෙලා කරේ.
අපි ඒකට එමු. ඊට කලින් කියන්නේ මේ වෙන ඔපරේෂන් හිරිවට්ටලා හරි සිහි නැති කළා හරි කළා තියෙනවද?
සිහි නැති කරලා තමයි ડોක්ටර් කරේ.
හරි.
ඒ දැන් අවුරුදු 10කට විතර කලින් එක කරේ.
කැමරා දාපු ඔපරේෂන්.
ආ.
ඒ මේ විස්තරේ පොඩ්ඩක් පැහැදිලි කරනවද? ඒ මොනවා වෙලාද මේ ඒ පරීක්ෂණ?
ඒ බඩේ කැක්කුමක් ඇවිල්ලා තමයි ඔපරේෂන් කරේ. මොකද්ද පිත්තාශයද මොකක්ද අයින් කරනවා කියලා තමයි කිව්වේ ડોක්ටර්.
පිත්තාශය අයින් කරනවා කියලා ඔපරේෂන් එකක් අවුරුදු 10කට කලින් කරා.
ඔව්.
ඒ විස්තරේ මට පොඩ්ඩක් කියනවද? ඒ මොනවා වෙලාද ඉස්පිරිතාලේ නතර වුනේ?
බඩේ කැක්කුම හැදිලා ડોක්ටර්.
අර බඩේ
ඊට පස්සේ බඩේ කැක්කුම හැදිලා ඊට පස්සේ මට බෙහෙත් දුන්නාම අඩු වුණා. ආපහු සති 8කින් විතර එන්න කියලා තමයි ඔපරේෂන් එක කරේ.
සති 8කින් එන්න කියලා ඔපරේෂන් එක. හරි. ඒක කැමරා දාලාද කරේ ඔපරේෂන් එක?
ඔව් කැමරා දාලා කරේ.
හරි. එතකොට දැන් මේ වෙන ඔපරේෂන් මොනවත් කරලා නැහැ.
වෙනම හර්නියා එකක් හර්නියා ඔපරේෂන් එකක් කරලා තියෙනවා දැන් ඒක අවුරුදු 20කට විතර කලින්.
ඔව්. ඒ මොන පැත්තේද?
දකුණු පැත්තේ.
හරි. වෙන ඔපරේෂන් නැහැ නේද? බෙහෙත් කෑම ප්ලාස්ටර් මේ ඇලර්ජි වෙන ගතියක් තියෙනවද?
ඇලර්ජික් නැහැ. ඉස වෙලා නැහැ මොනවා.
හරි. අර මේ ඩයි දාලා ඉන්ජෙක්ෂන් මොනවත් එහෙම කරලා නැහැ නේද? ලොකු මේ රවුමක් වගේ CT මැෂින් කියලා අහලා තියෙනවද දන්නේ මහත්තයා? එහෙම කරලා තියෙනවද?
දන්නේ එකක් කරා ડોක්ටර්.
ඒ මේ කොයි කාලේද අර කලින් සැරේ?
දැන් ගිය සතිය වගේ කරේ.
ගිය සතිය. ඔව්. හරි. මට ඒ ගිය සතියේ දැන් මේ සති 3කට කලින් මහත්තයා ඉස්පිරිතාලේ නතර වුණයි කිව්වනේ.
ආ.
මේ ඇඟ කසනවා මුත්‍රා යන පාට ඒ ටිකත් එක්ක. එතකොට දවස් කීයක් නතර වෙලා හිටියද?
සති එකමාරක් දෙකක් විතර හිටියා.
ඊට පස්සේ ඒ කාලය ඇතුළත මොනවද කරපු මේ විශේෂ පරීක්ෂණ වගේ ලේ ගත්තා, සේලයින් දුන්නා. ඒ ටිකට අමතරව මේ කටෙන් කැමරාවක් දාලා වගේ මොන හරි කරාද?
නෑ
පරීක්ෂණයක්?
නෑ.
එන්ඩොස්කොපි කියලා මහත්තයා දන්නවද?
කටෙන් කැමරා දාන්න ඕන කියලා එකක් කරා ડોක්ටර්.
එතකොට ඒ කියන්නේ මේ අර වෙනම කාමරයකට ගෙනහිල්ලා
ඔව් මට හැබැයි සිහිය නැතිබුණ නෑ හැබැයි. කටෙන් දානවා කියලා මගෙන් අස්සන් එහෙම
ගත්තා. හරි. එතකොට ඒක දැම්මට පස්සේද මේ අර ඇඟ කසන ගතිය
දැන් හොඳයි. දැන් අඩුයි ડોක්ටර්. සෑහෙන අර කණ්ඩ අමාරු ගතිය කණ්ඩ අපිරිය ගතියක් නම් තියෙනවා ඉතින්. ඒත් ඒකත් පොඩ්ඩක් හරි ගියා.
කෑම කණ්ඩ අපිරිය ගතිය තියෙනවා තාම.
පොඩ්ඩ සාමාන්‍ය තියෙනවා. ඉතින් කලින් තරම් නෑ ડોක්ටර්. කලින් තිබ්බ අමාරු ගතිය සෑහෙන අඩු වෙලා තියෙනවා.
කොච්චර කාලෙ ඉස්පිරිතාලේ නතර වෙලා හිටියද?
ඔක්කොම සති එකහමාරකට දෙකකට කිට්ටු
විතර
වෙලා
හිටියා.
හිටියා. ඊට
ඒ
පස්සේ මට
කාලේ
ගෙදර යන්න කියලා තමා එන්න කිව්වේ ආපහු.
ආයි එන්න කිව්වා
ඔව්
ඉස්පිරිතාලේ. හරි.
ඔව්
එතකොට ඒ කාලේ ඇතුළත
ඔව්
ඔයාව අර CT පරීක්ෂණයක් කියලා අර ලොකු රවුමක් වගේ තියෙන මැෂින් එක
ඔව්
අර
ඔව් ඒක කරේ ડોක්ටර් අර මේ සිහිනදි කරලා කරපු පරීක්ෂණය කරන්න කලින්.
ඒකට කලින් නේද?
ඔව් ඔව්
ඔව්. ඒ මැෂින් එක ඔයාට මතක විදිහට ලොකු සද්දයක් එන මැෂින්
නෑ
එකක්ද ගොඩක්
නෑ
වෙලා ඉන්නේ නැත්නම්
නෑ
සද්දයක්
නෑ
නැති
නෑ
පොඩක් වෙලා හිටපු
මං
මැෂින් එක?
මට මතක විදිහට මොකද්ද CTද මොකද්ද කියලා තමයි කිව්වේ
CT
ડોක්ටර්.
මැෂින් එක
ඔව්
නේද? හරි
ඔව්
හරි.
ඔව්
තාම කෑම රුචිය කෑම කණ්ඩ අපිරිය ගතිය ඒක තියෙනවා.
ඔව්
අවස්වර වලට
පොඩ්ඩක්
ගෙට්ටු ගතිය.
තියෙනවා.
හොඳ
පොඩ්ඩක්
ගතිය තියෙනවා.
තියෙනවා. වෙනදට වැඩි ටිකක් විතර කන්න පුළුවන් ඒක.
හරි.
ඇඟට හොඳ ගතියක් දැනෙනවා.
ටිකක් තියෙනවා. හරි. ඒත් එක්කම ඔයා මේ දත් මදිනකොට ඉක්මනින් ලේ යන ගතියක් එහෙම තියෙනවද?
එහෙම නම් තිබුණේ නෑ ડોක්ටර්.
නෑ. මුත්‍රා
නෑ.
කරනකොට ලේ යන ගතියක්, টয়ලට් යනකොට ලේ යන ගතියක් එහෙම නෑ.
එහෙම මොකුත් තිබිලා නෑ.
ඔයාට දැනෙනවද වෙනදට වඩා හවස් වරුවට රැයට එළියට බහිනකොට ආලෝකයේ අඩු වෙලාවට ඇස් පෙනීම දුර්වල වෙලා තියෙනවා වගේ?
දැන් අර පොත්පත් එහෙම නම් වැඩි කියවන්න මම කණ්ණාඩි දානවා. ඒ ඇරෙන්න වෙන ප්‍රශ්නයක් නෑ ඒක.
වෙන මොනවත් ප්‍රශ්න නැහැ.
නෑ.
හරි. එතකොට ඔයා දැන් මේ බෙහෙත් ගන්න අසනීප තියෙන්නේ ප්‍රෙෂර් එකයි කොලෙස්ටරෝල් එව්වට ගමේ ක්ලිනික් එකටද යන්නේ?
යන්නේ ඔව්.
ඔව්. එව්වා හරි. එතකොට මහත්තයාගේ පවුලෙන් යන අසනීප මොනවත් තියෙනවද? වකුගඩු ප්‍රශ්න?
එහෙම මොකුත් එහෙමනම් දන්න විදිහට
අම්මා
ડોක්ටර්
තාත්තා අක්කා නංගි
අපේ මේ අයියා කෙනෙක් නම් නැති වුණා. මොකද්ද බඩේ මොනවා හරි කැන්සර් එකක් කියලා පිළිකාවක් කියලා මට ඒක මොකද්ද කියලා නම් දන්නේ නැහැ හරියට.
හරියටම දන්නේ නැහැ. මොලේ පිළිකා එහෙම තිබිලා තියෙනවද?
එහෙමනම් දන්නේ නැහැ.
එහෙම දන්නෙත් නැහැ.
නෑ.
වකුගඩු ප්‍රශ්න පවුලෙන් යන්නෙත් නැහැ.
නෑ.
පියවරු පිළිකා තිබිලා තියෙනවද?
දන්නේ නැහැ ડોක්ටර්. එහෙමනම් දන්න කට්ටිය නම් නැහැ එහෙම ඉතින්.
හරි. එතකොට මහත්තයාගේ ළඟම ඉස්පිරිතාලේ කොහෙද?
ගල් නෑ මේ පොඩි ඉස්පිරිතාලයක් තියෙනවා ડોක්ටර්.
ඉස්පිරිතාලේ. මහත්තයා නෝනත් එක්කද ඉන්නේ? ගෙදර කාත් එක්කද ඉන්නේ?
දැන් නම් නෝනත් එක්ක ඉන්නේ පොඩි පුතත් ඉන්නවා මාත් එක්ක.
හරි. පොඩි පුතාගේ වයස කීයද?
පොඩි පුතා කැම්පස් එකේ ඉන්නේ ડોක්ටර්.
එතකොට හදිසියක් වුණොත් ඉස්පිරිතාලට යන්න වාහනයක් තියෙනවද? කොච්චර වෙලා යනවද?
අපේ අනිත් පුතා ඉන්නවා ළඟ. එයාට එහෙම වාහන නම් නැහැ ඉතින්. ට්‍රීවල් එකක් තියෙනවා. ඒකේ තමයි ඉතින් යන්නේ.
හරි. 19 90 කියලා මේ හදිසි මේ ඉංග්‍රීසි
ඒ පැත්තේ මං හිතන්නේ තියෙනවා ඒ පැත්තේ.
හරි.
මං ගිහිල්ලා නැහැ. පුතත් එක තමයි ඉතින් ගියොත් යන්නේ.
මහත්තයා ළඟදී කියන්නේ රට යන්න නැතුව ඇතිනේ. චීනය වගේ නෑ නේද?
නෑ එහෙම රට ගිහිල්ලා නෑ මං කවදාවත් ගිහිල්ලා නෑ.
ඔව්. එතකොට මෙහෙම ඇහුවට මේ මොනවත් හිතන්න එපා. මහත්තයාගේ මේ මත්පැන් බීම කොහොමද?
දැන් නම් බොන්නේ නෑ ડોක්ටර් මම.
ඔව්. ඉස්සර කොල්ල කාලේ කොහමද මේ
මම මේ ඉතින් ඒ දවස්වල නම් ඉතින් බිව්වා දැන් මෑතක් වෙනකම්ම බිව්වා ඉතින් ඇත්තටම බොරු කියන්න බෑනේ මහත්තයා.
එතකොට මේ පටන් ගත්තේ අවුරුදු කීයෙන් වගේද?
කොල්ල කාලෙන් පටන් ගත්තා. ඉතින් ඒක දවස්වල නම් ඉතින් එහෙම ඉතින් ටික බිව්වේ. අන්තිම කාලේ නම් ටික වැඩි වුණා හැබැයි. එහෙම ලොකුවට බොන්නෙත් නෑ.
සාමාන්‍යයෙන් සතියට දවස්
2-3ක්
විතර බොනවා. සාමාන්‍යයෙන් සීල් ආරක්කුද බොන්නේ නැත්නම්
එහෙම විශේෂයක් නෑ ඉතින්. තියෙන එකක් බොනවා.
සාමාන්‍යයෙන් බොනකොට කොච්චර ප්‍රමාණයක් වගේ බොනවද?
කාලක් වගේ. කාලයි සමහර ඊට වැඩිත් වෙනවා.
සිගරට් බීම සිගරට් බොනවද? බීඩි බොනවද?
ඉඳලා බොනවා.
සාමාන්‍යයෙන් නිතරම පෙවෙන්නේ නැහැ.
නිතරම කියන්නේ ඉඳලා බොනවා ඉතින් එහෙම විශේෂ දවසට එකක් දෙකක් පෙවෙනවා ඉතින්. දැන් නම් නවත්තලා තියෙන්නේ ડોක්ටර්ස්ලා කිව්වා මොකද බොන්න එපා කියලා දැන්.
හරි. එතකොට මහත්තයාට මේ අසනීප ගැන මොනවද හිතෙන්නේ?
දැන් නම් ડોක්ටර් මට හොඳයි.
ඇඟට තේරෙන්නේ
මේ ડોක්ටර්ස්ලා නම් කිව්වා මොනවා හරි තව එක පරීක්ෂණයක් තියෙනවා ඒක කරලා බලලා
හරියට විස්තර කිව්වද කවුරුත්?
හරියට අපේ ගෙදර කට්ටියත් එක්ක කතා කරන්න ඕන කියලා නම් කිව්වා.
හරි මහත්තයා. එහෙනම් මේ සැරේ අපි කරන්න
Right, okay. Thank you.
Thank you, sir.
So, how many minutes have you taken?
15 minutes.
15, right, okay. 50. Okay, right. So for entire history and examination, you have 15 minutes, right? So in the examination, what are the things you are going to do in this patient?
I will first start with the general examination.
Mhm.
I will see the icterus and sclera for deep colored icterus and
Okay,
pallor.
patient is deeply, so now just some icterus is there, residual icterus is there.
Yes.
Okay, residual icterus is there.
And I would, before that, I will see if the patient is well looking and the hair distribution is normal and looks.
Yes, those looks normal, right? Okay.
And see the dental hygiene for in case of intubation and surgeries. And then I would proceed to the cervical lymph nodes and the Virchow's node to see if there's any features of metastasis. And
Okay.
then I will go for the hand, see the pulse, if there is any clubbing, to exclude cirrhosis like chronic hepatitis conditions, and see features of decompensated liver disease such as leukonoikia, and features of nutrition deficiencies like koilanoikia. And also, I would like to see if there is scratch marks in the torso and the limbs.
So you expect in this patient?
Not at this setting,
Not,
maybe in the
okay.
first.
Yes, you should, as general, you need to check, okay? Because patient no itching now, right now, right? Okay.
And see for lower limb edema, just to see if there's any decompensated liver disease. Maybe. And then I would go for the examination of the abdomen. In inspection, I would like to see if there's any obvious masses and if the abdomen is distended or not.
Okay.
And as he's a well-looking
So
patient.
assume that this patient hasn't had any kind of intervention you elicited in the history, right? So what are the, and assume that patient never had any kind of intervention. Fresh patient, right? Just first presentation to the hospital with obstructive jaundice, right? So what are the things you are going to see in the abdominal examination? What is the thing you need to check? If you mention that thing, that is the only thing basically we need.
I would, if I had to check one thing, I would say for the palpable gallbladder.
Very good, excellent, right? So you need to check for the palpable gallbladder. So do you think that you get the palpable gallbladder in this patient?
I think in this patient, it's unlikely due to the stenting.
Why? And what else? What else in the history?
And yes,
patient had the lap coli, right?
yes.
Okay. Right. Patient had the lap coli, so so no gallbladder, right? So you need to remember that in the examination, in the history taking bay, right? So usually you're not going to question there, right? They just allow you to examine. Sometimes they might ask some question, right? So usually they are not allowed you to ask any question. The examiners, they just observe and things. So, but when you mention the thing, so imagine that fresh, the virgin patient, no any previous surgeries, no kind of ERCP kind of intervention. So just you need to look for the palpable gallbladder. Please remember that, right? So that is, if you miss that thing, so it's not a good thing, right? So it's not necessary to be palpated for you, even though it is distended. So, but at least you need to look for, right? So how do you need to escape those kind of things is, I couldn't palpate the gallbladder, but I would like to confirm it with the ultrasound scan. Simple. Those kind of things you can. So if pretty obvious, well palpable gallbladder, you should not miss those things, right? Okay, go ahead.
And in this patient, I would see for the laparoscopic scars.
And
Okay,
it's there, right? Okay.
And if there is any changes in the umbilicus,
Mm-hmm.
such as ulcerations,
Mm-hmm.
and if this patient presented previously for scratch marks and features of decompensated liver disease, such as caput medullae and dilated veins.
Okay.
And then I will go for palpation.
Mm-hmm.
And in palpation, I would
palpate. So without telling inspection, palpation like that, what are the things? The one thing is palpable gallbladder, other thing is any other masses, right? Hepatomegaly, splenomegaly, free fluids. I look for those things. You just mentioned those. So that also depend on depending on the examiner to examiner, right? So you should not follow so you don't know what kind of examiner you get for the exam. You just stick onto the basic things. That's all right, your way, right? Okay. Okay, good. Go ahead. That's all. So you need just for the completion, you need to check the lungs, because patient is a smoker, those kind of things, right? Okay.
And,
right. Yes. Okay.
Basic pronated drift for CNS examination.
Right. Okay. Right. So now the others need to, right. Okay. So I'll do the, so this is the end of the observed history taking. Okay. And the targeted examination. And you will have 5 minutes just to prepare for your summary, and then proceed to the, so I won't give you 5 minutes, right? Okay. So it is a waste of time, right? So, so usually you have 5 minutes just to prepare the summary and just summarize the things. And then in the next panel, different kind of examiners, two different examiners. And so they will ask about the discussion. So I will do a discussion with you as well. Okay, right. So remember that you won't penalize. So remember that if you miss the things, you forgot to ask the jaundice, right? So this patient presented those kind of things. Think that, and at the time you examine, patient is not jaundice, but you somehow miss. So you won't penalize from there. Remember that, right? So, but those all are human. So because of that reason, so you will get less mark. But ideally, so they mentioned that you won't penalize depending on the what you have done in the observed history taking. Okay, right. Okay, can you summarize the things? And I will then do the discussion like we do in the exam, right? Then I will discuss the history, and then at the end, I'll just go through a presentation. Okay. Okay. Can you summarize the history? Just I'll give you just 1 minute, right? Okay. Is that okay? Right.
"58-year-old farmer presented with features of obstructive jaundice, including deep icterus, pale stools, pruritus, and dark-colored urine for 3 to 4 weeks, associated with loss of weight and loss of appetite. And this time presented for further interventions, who has had a past medical history of hypertension and dyslipidemia, with past surgical history of right side hernia repair and a laparoscopic cholecystectomy with no known allergies, and a positive family history of gastrointestinal cancer with good socioeconomic background."
Okay, right. So I just go to the audience, right? Okay. So any one of you just on your mic, and so you must have listened the conversation, right? So one of you can summarize. So whatever. So if you haven't listened, you just mention, you just make a summary and can you present? Okay, I'm going to name someone, right? Is that okay? Don't, don't, please don't left, right? Please don't leave the, right, okay.
Sir,
Don't name me.
58-year-old farmer who is a chronic alcoholic and a smoker with a med score of more than 4 and ASA1, presented with features suggestive of obstructive jaundice with associated loss of weight and loss of appetite for 2.5 months duration, without any significant other clinical features.
Okay.
He's having a past surgical history of laparoscopic cholecystectomy and a hernial repair, and a past medical history of hypertension and dyslipidemia. He's having a family history of intra-abdominal malignancy, and on examination, he's clinically hemodynamically wise stable, and features of obstructive jaundice are there, but there's no palpable gallbladder, and currently awaiting for
Okay.
procedure.
Good. Right. Okay. So the Binu, right?
Yes, sir.
Binu, right? Okay. Yes, Binu, right? Okay. You are now in the. So we'll discuss everything after that, right? So right. So imagine that this patient comes to you to the clinic, right? So this is the first presentation. So what are you going to do? So you mentioned that so this patient got icterus and T-color urine. So what is the reason for that?
Obstructive jaundice due to the pigments being circulated in the.
So what is the reason for T-color urine? What is the reason for pale stool? Why patient develop itching?
Because the bile is not secreted into the gastrointestinal tract.
Okay.
Which
Because
cause
of the obstruction. Okay.
obstruction. So the bile pigments give color to the stools, and due to the bile pigments not being excreted through the normal GI tract, it is been circulated in the systemic circulation, which is filtered partly through the urine, which gives
and that was the color to the urine, T color to the urine, and
color to the urine,
less color to the stool.
As well as the other icterus and palmar.
Okay, right. So why itching?
Due to the bile salts deposited along the.
Okay, good. Right. Okay. Right. So you need to know about the rough things. I mean, the basics things about that. So as you learn it in the biochemistry, right? Biochemistry, right? So you just need to know. So what is the pathway of that? Sometime it can be asked. Okay. Right. Okay. So what are you going to do? So imagine that this is the first presentation, right? So you are either in the clinic or in the admitting ward. So patient presented obstructive jaundice. Okay, features of jaundice. So you clinically assess, and so what are your thoughts on this patient? So what do you think this patient is got?
according to my history and examination, my differential diagnosis will be most probably malignant lesion. It could be a head of the pancreas cancer. It could be the first presentation in a periampullary cancer. Could be a cholangiocarcinoma. Or a cancer in the yes, those will be my top
So
differential.
basically cancer.
Yes.
So why do you say that this is likely to be a kind of either one kind of cancer you mentioned? What is the reason? So can you just elaborate on that?
Obstructive
So why do you say that? Yes.
This patient is having deep jaundice, which is most probably an obstructive type. It can either be intrahepatic or extrahepatic.
Okay.
And yes.
So what is the reason to say that this is more likely to be malignant than benign? So that's it. So in ideal situation, right? Remember that you get there are mixture of symptoms you get, right? There are the ideal, I mean, book එකේ කියන විදිහට book එකේ කියන විදිහට කියන්නේ ideal symptoms for the malignancy. There are symptoms for the benign things like stones. And there are some patients, you can get some mixture, right? So you need to balance those things, right? There are things for malignancy. You need to know what are the things for malignancy in this patient. And what are the things against malignancy in this patient? And what are the things for to say that benign diagnosis? What are the things? What are the things against benign? Can you get my point?
Yes, sir.
Okay.
The first point will be he's 58 years old. So that is malignancy is more prevalent. The prevalence increases with the age in malignancy. So that would be the first.
So age, you mean? Age. So can't you get stones in 58 years?
Yes,
Right.
but
what is the most
constitutional symptoms, including
progressive jaundice? Progressive jaundice. Here, progressive jaundice until he present to the hospital and do some intervention. Progressive jaundice. So it most of the time it's been malignant. Even it can be a benign things. Once you investigate, that's why we need to do the investigation, right? Okay. What else? Progressive jaundice. What are the other things in the history to say that this is malignant?
constitutional symptoms, including the loss of weight and loss
of weight, loss of appetite. Okay, very good. Okay, right. If those are there, it's more suggestive of malignancy. Right? Okay. So those are the things. And so what else?
And
so what are the things? Yes. So what are the things? What else? Okay.
The loss of weight is significant along with.
Right. Okay. Right. Tell me, what are you going to do to this patient? You clinically assess and you assume that this may be a malignancy. Right. So what are the things you are going to do? How do you investigate this patient?
I will have to do investigations to see the general well-being of this patient. For that, I will do the full blood count, urine full report, and serum bilirubin, along with the liver function test like clotting profile. I would also see the renal assessment in this patient, including serum.
Okay.
Yes, and
so without hitting around the bush, right? You just mentioned. So what are the basic things you need to do the most of the investigation in this kind of situation? So, but to confirm that this is obstructive jaundice, you just clinically know that this is obstructive jaundice. To confirm that this is obstructive jaundice, what are the investigation you are going to do?
total bilirubin, direct and
Okay.
indirect fractions.
Total and direct fraction. Indirect, you need to calculate and get, right? Okay. And so now, of course, they mention the indirect fraction, right? Okay. Okay. What
And
else?
urine for bile and bile salts.
Hmm. So are we going to do those things nowadays? So you can do
with the direct and indirect fractions. I can get an assessment about if it's obstructive or not. And also,
sorry, I didn't get. Sorry.
With the direct and indirect fractions, as well as ultrasound scan of the abdomen.
No. What else in the liver profile? You need to check.
And AST, ALT, as well as gamma GT and alkaline phosphatase.
Okay, what will happen to alkaline phosphatase and gamma GT?
In obstructive type, it will increase than the normal.
Okay. And
there can be a mild elevation of aspartate aminotransferase and alanine.
AST and ALT. Okay, right.
And direct fraction will be.
So if it is like thousands, AST and ALD is like thousands. So what it implies?
There is some hepatitis.
Some hepatocellular damage.
Hepatocellular damage.
So maybe your diagnosis is wrong, right? Thinking that this is obstructive, the obstruction of the extra hepatic biliary system is maybe wrong, right? So maybe kind of a hepatitis. There are mixed picture in that situation, right? Okay. What else? So what will happen to the gamma GT? So tell me what are the other instances ALP can get increased?
It can be increased during bone dissolving diseases like osteoporosis.
Okay, any fracture, okay, right, okay, and
will be increased in a
pregnancy,
and if they are
in children, right? Okay, okay. So what about the gamma GT? What will happen to the gamma GT?
Gamma GT usually in obstructive type it will be increased, but also it will be increased in as this patient is a chronic alcoholic. I would expect higher.
Yeah, okay. That's why you do both alkaline phosphatase and gamma GT, right? Okay. Right. What is the next? So to assess the complications of jaundice, so what are the investigations?
I would go for the PT-INR because it's the most first to derange in the liver function tests.
Sorry? So I just went to the chat box. Sorry. I just distracted, right? I'll read those later, right? Okay. Just tell me, right? Okay.
I would do the PT and INR to see the...
PT-INR, okay. PT-INR, basically PT-INR, right? Okay. So, so why you do the PT-INR in case of patient of jaundice?
Because it is the there are two reasons. The first one is because vitamin K is a fat soluble vitamin, and due to the bile salts being obstructed, absorption will be impaired. And also it can be if there is a hepatocellular damage and chronic liver condition, also it will be decreased.
Okay, right. Right. Okay, so imagine that you get a high PT-INR patient. You are going to have some kind of procedure, invasive procedure. INR is assume that 2. So what is the best way of correcting that thing? You have time.
Fresh frozen plasma or...
So you need to immediately correct. You can use that thing, FFP or factor 7.
Right.
Or those are just to correct the immediately, right? Okay. If you have time, what is the best way?
Vitamin K.
Yes, vitamin K. Okay, good. Right. Okay, right. Okay. You all right?
Yes, sir.
Okay. And, right. So what are the other investigations? So, මෙහෙමයි ඔයා ඔක්කොම එක සැරේ අහන්නේ නැහැ. Okay, එකක් දෙකක් අහන්න පුළුවන්. Right? Okay. Just to check your basics. Okay? Right. Right. What else? So, right. So, suppose that you have done all the relevant investigations, blood investigation, biochemical things. So, tell me about the imaging. What are the things you are going to do? Imaging studies.
First line, I would go for ultrasound abdomen and the hepatobiliary tree.
Okay, ultrasound of the hepatopancreaticobiliary. Ultrasound HPB, or we just mentioned ultrasound abdomen. So what are the things you are going to see in the ultrasound scan?
I would like, if there are stones and duct dilatation, extrahepatic duct dilatation.
What else? You're just starting either from liver or out to inner or inner to out. So whatever the way. So what are the things?
If there are gallstones.
So one thing is whether there are any stones or not, right? So in this patient has had the lab choline. So we can't comment about the gallbladder, right? So imagine that this patient never had patient hasn't had any surgery before, right? So you need to comment about whether gallbladder is distended or not, right? What else?
If there is any
intrahepatic and extrahepatic duct
dilatations.
Okay, any cause for the obstruction is visible or not? Sometimes it may be visible, right? What else? One last thing.
Porta hepatis lymph nodes.
Maybe.
And
so you can easily see the liver, right? So what are the things you are going to see in the liver? So if you are suspecting malignancy in some patients, it can be there. Metastasis. Okay, whether there are any mets or not. If mets are there, sometimes so depending on the so we are having a critical situation to get some investigation. So you can cut down those investigation. So if you detect confidently, radiologists mention that this is kind of a mets or like that, right? Sometimes, so usually we do, but you may avoid other unnecessary the other investigation, right? Okay. You can just start palliation from that point onwards. Okay, but it right. Okay, those kind of right. What is the next thing? Right, in the ultrasound scan, extrahepatic and intrahepatic duct dilatations are there. Gallbladder is surgically gallbladder is absent. Right, liver looks all right. So cause is not identified in the ultrasound scan. So that is the report there, and no free fluids, right? So what is the next investigation? Yeah. So the bile duct is dilated up to the upper part of the duodenum, the first part of the duodenum, right? So even distal CBD is dilated, right? So what is the next investigation you are going to do?
If there are no stones and there is a duct dilatation, I would go for a contrast enhanced CT.
Yes, contrast enhanced CCT, chest, abdomen, and pelvis. CCT cap, right? CCT, chest, abdomen, and pelvis. So what are the things you are going to see in CT scan of this patient?
My differential diagnosis, I would like to exclude starting from the point of obstruction.
You can repeat the things you find it in ultrasound scan, right? Intrahepatic duct dilatation, extrahepatic duct dilatation. So most of the time, so you can identify the cause for the obstruction, whether there is any mass in the pancreatic region, second part of the duodenum, distal CBD, right? Or whether there's any lesion in the hilar region, right? Or some other things, right? And other thing is any metastasis to the liver, lymph nodes, right? those kind of things. There are a lot of things to see. Okay, right. Imagine that this patient got hilar lesion. Okay, Binu, are you here?
Yes, sir.
Okay. In the the CT scan, right? CT scan, there is a hilar lesion. Forget about the ultrasound scan. In the ultrasound scan also, just intrahepatic duct dilatation and the proximal part of the duct are dilated, right? Distal CVD is not seen. In the CT, there is a hilar lesion, right? So what is the next investigation if you want to, right? What is the next investigation you may request? So that of course decided by the consultant, but okay. What is that?
MRCP.
Yes, very good. What is MRCP stand for?
Magnetic
resonance cholangiopancreatography. Okay, MRCP. So what are the added thing you get from MRCP than the CT?
The
Right. Okay.
biliary
So
tree.
you can see the biliary tree well, how extent it's gone, right? Whether it is extend to the left duct, right duct, like that, you can get the things. CT, of course, you can get for a certain extent, but to get the precise things, you need to have the MRCP. Okay, imagine that this patient got the distal, the CA head of the pancreas, right? Okay, so what are the options? No distal mets, portal vein, superior mesenteric artery. So it looks resectable. So what are the things you need to do?
Then I will have to assess the patient's fitness for surgery.
Okay, patient fitness. Okay, you assess. Suppose that patient is so it's having a reasonable fitness. Okay.
Then
the patient can undergo the major surgery, complex major surgery, right? Okay.
I would go for a multidisciplinary approach.
Very good. So you need to discuss this patient in MDT, right? Multidisciplinary team, right? Which include who are the members in the MDT?
Team leader, general surgeon, ideally a specialist in subspecialist in that field.
Okay.
Along with the anesthetist, oncologist.
Okay.
And family member, as well as
basic components. Basic are the surgeons, group of surgeon. I mean, there are maybe oncosurgeon, maybe general surgeon, special interest in those areas, and maybe GI surgeon, right? Anyone who is capable of doing those kind of surgery, right? Surgeons, oncologist, radiologist, don't forget the radiologist, right? Radiologist, and anesthetist, of course, for the primary MDT we are not getting, right? So in other countries we do have the coordinators for the MDTs, right? So basic, at least those people need to be there. Okay, at least, right? Okay, right. So after MDT, so what would be the right? So what are the surgical options available? Everything is all right. What is the surgery you are going to perform? Not you, your team is going to perform.
Pancreatoduodenectomy would be the surgery.
So what is the simple name? Whipple's procedure. In the Whipple's procedure, So what they are going to remove, and so what are the kind of reconstruction they are going to make?
In the conventional peoples, they will be removing the head of the pancreas along with the tumor extent and the duodenum, maybe the complete duodenum.
Right, okay.
Or
Okay,
the
okay, right.
second
Right.
and
Right. So we can discuss the part of the stomach, entire duodenum, part of the jejunum.
jejunum.
That part of the pancreatic head of the pancreas, with the bile duct, including the gallbladder, if it is there. Okay. So those are the things we are going to remove. With the lymph nodes are there, you can remove the lymph node as well. Okay. And what are the reconstruction? Just name.
Duodenal hepatostomy, gastrojejunostomy, and
yes, gastrojejunostomy. So what are the things you need to reconstruct? So you need to correct the bile flow.
Bile flow.
Okay. You need to correct the pancreatic juice flow, right? Pancreatic things and the alimentary tract. Okay. So for the bile, you do hepaticojejunostomy, and for the hepatico mean the bile, the hepatic duct selling that name, right? Hepaticojejunostomy, and for the pancreaticojejunostomy, and for the alimentary tract, gastrojejunostomy. Those are the three reconstruction, right? You just remember those things. You won't penalize not knowing those kind of things, right? So, but you need to know very well about the basic things. Okay. The initial thing I asked, right? Okay. Okay, good. Any question for you? Right. Now others also need to join. Okay. There are 308 participants. Okay. I need most of your participation for these things, right? Okay. Right. In the history, so what are the things he has missed?
What came first? Was it the loss of appetite or the loss of weight?
Sorry. Who is this? Right. Okay. Just so which one come first?
So in carcinoma of the pancreas, loss of appetite will come. It's the main thing that happens.
Okay.
But and there also is the jaundice preceding the loss of appetite, or does the loss of appetite happen first? Because in carcinoma head of the pancreas, loss of appetite occurs before the jaundice, but in cholangiocarcinoma, loss of appetite occurs after the jaundice. Then there's also features of local spread. For example, was there any history of gastric outlet obstruction?
Okay, right. Try to have some local spread and distal things, but I didn't feel that actually, right? Okay, what are the things you need to ask? For the local, so what are the things for the local spread? He asked certain things actually. Huh? So what are the things for the local spread? Okay.
So it could be involvement of an organ or the vascular involvement. So if it involves vessels, there can be upper GI bleeding.
Okay, he asked about the upper GI bleeding. Ask about the melena. I think he asked about those, right? Not about the hematomesis, but ask about the melena, right? Am I correct, Binu? Yes, you ask about the melena, right?
Yes, sir.
Okay.
Gastric outlet obstructive, sir?
Yes. Features of gastric outlet obstruction. He asked about the vomiting, but I don't know what is your intention was, whether to ask about the gastric outlet obstruction or not. Right. Okay. Anyway, what else? He asked about the pain actually. Yes, you need to ask about the. So actually, remember that painful and painless mean. So in case of here, of course, the pain is kind of a biliary kind of pain, right? Like previous episode of biliary colic, right? sudden onset severe pain in the right upper quadrant, radiate to back associated with nausea, vomiting, those kind of things initially was there or not. So that is the pain, whether it is painful or not, right? Followed by jaundice. And it settled maybe in a couple of days and like that, okay? And in some patient with malignancy, they may have some pain because of the infiltration, right? So that is vague, dull pain, right? You should not just remember that you should not just complicate that with the this is painful or painless like that, right? Okay, you got my point. Again, පාටලව ගන්න එපා ඒක pain එක කියන එක, right? Okay, right. What else?
So other complications of obstructive jaundice, like the day-night reversal, which is sleeping pattern, like history of reduced urine output due to hepatorenal syndrome.
Yes, about the reduced urine output, just features, 1 or 2 features suggestive of what hepatic encephalopathy, you mean that, right? Okay, right. What else? He asked about the bleeding, right? Okay. So what are the features of distal meds?
So for the involvement of the liver, it would be, he mentioned those, the loss of appetite, loss of weight, right hypochondrial pain can also be one. And then if it's involvement of the lung, there can be a chronic cough, hemoptysis.
Okay, so for all the kind of distal meds, there are sets of questions, right? For the bone meds, intractable backache, right? Depending on the site of the cancer, if it is in the upper part, thoracic vertebra. If it is in the lower part, in the lumbar region, right? Pathological fractures, right? Intractable backache means, so you should not just ask වාගේ කොන්දරි දෙනවද, right? So ඉවස ගන්න බැරි බෙහෙත් වලට අඩු වෙන්නේ නැති pain එකක් තියනවාද? රැට වැඩිද? Those kind of things you need to ask. Okay? Right. So that's for the bone meds. Liver meds, right hypochondriac pain. The may not be relevant. Jaundice, right? Those kind of things. And for the lung meds, dyspnea, hemoptysis, pleuritic type chest pain, those kind of things. Okay. For the brain meds, early morning headache, vomiting, those kind of things, right? There are sets of questions, right? I assume that you, all of you know about those things, right? Okay. So what else he missed? Binura, can you just remember things you missed? No, right. Okay. Others, come on. Sorry? Sorry, I can't hear you. I can't hear you properly. Please.
What has done up to now?
What has done up to now? Very good. Okay. ඒකත් මං හිතන්නේ ඇහැව්වා. Yes. For a certain extent, he asked about those things, right? Okay.
So
the drug history.
Drug history. Okay. Drug history. Right. In the major things, like in the history of presenting complaint, what are the things he missed? Right. Okay. So I'll discuss from the beginning now, right? Okay. So when you get a patient with obstructive jaundice, okay. When you get a patient with obstructive jaundice, you need to, සමහර patient ලා කියන්න පුළුවන් මගේ ඇස් කහ වෙලා ආවේ කියලා. එහෙම වෙන්න පුළුවන්. Right? So and සමහර patient ලා ඉන්න පුළුවන් itching, loss of appetite, those whatever the presentation somehow. So you need to get to the the single presenting complaint. That is the best thing. Single presenting complaint. What usually so what you are usually get used to the things. So what are the things you, I mean, in case of obstructive jaundice patient, so what is the presenting complaint you need to find out. Camera එක on කරලා කවුරු හරි කියන්න, right? Okay. Or maybe Binu. Who is going to answer that question?
So we can ask the patient මේස ඉස්පිරිතාලට එන්න හේතුව.
Yes. එතකොට නෑ අපි කියන්නේ එහෙම ඇහුවාම patient කියන්න පුළුවන් එක එක ඒවා කියන්න පුළුවන් නේ. ඒ කියන්නේ පරීක්ෂණයක් කරන්න කියන්න පුළුවන්. එහෙම නැත්නම් maybe ඇඟ ගසනවා එහෙම කියලා. So but when you ask the question, if you find out that patient is having jaundice, even you observe, you just get that is the presenting complaint, right? You just follow that thing. Everything patient mentioned is associated symptoms. Okay? Right. Then, in the associated symptoms, what are the things you need to ask? Can you just switch on your camera and answer? So otherwise I'm just like speaking alone, right? Nothing will come to my mind, right? That's why I'm asking, right? Okay. Binu, at least you
Yes, sir.
Okay, right. You just keep your camera
Yes.
on, right? Okay, is that okay?
Yes,
Right,
sir.
okay. Okay. Right. Okay, so imagine that this patient obstructive jaundice. So what are the things you need to ask in the associated symptoms? You need to ask about the pale stool, tea color urine, right? And itching, those kind of things. If it is not come with the patient first, I mean, when you ask the question, if it is not come with the patient, you need to ask those things. And remember that you need to ask about the biliary kind of pain, whether patient is having a abdominal pain, biliary colic, previous history of biliary colic or not, or any kind of abdominal pain patient is having. Okay. And other thing is, you need to ask about the loss of weight and the loss of appetite. Okay. In the loss of weight and loss of appetite, you need to ask about the sequence. Which one come first? There is some clinical relevance in that thing, right? Whether it is progressive or not, duration, whether it is progressive or not, and whether loss of appetite and loss of weight, which one come first? Initially, loss of weight, loss of appetite, and then the jaundice. So it's likely to be the outside the biliary tree, right? The lesion is outside the biliary tree and causing infiltration, no compression on that thing, right? Okay. And so if it is inside the biliary tree, so those will come together. Loss of weight, loss of appetite, and those things come together. Okay, right. Then
So is there a way to differentiate between the cholecystitis versus biliary colic except for the field?
biliary colic and cholecystitis.
Yes.
Yes, in the biliary colic, it's maybe half an hour, right? Duration is shorter. So biliary colic, it progresses into the cholecystitis. Okay, the duration is longer, maybe days, right? The right hypochondriac pain persists for a days. If it is shorter period, so sudden onset, shorter period, it's biliary colic. Okay, right. Okay. Then of course you need to ask about you ask about the associated symptoms, loss of weight, loss of appetite, and then hematomesis, melena, vomiting, right? All the kind of upper GI symptoms, you need to ask about those things. Okay. And so in this situation, you need to think about the causes for the obstructive jaundice, right? Causes for the obstructive jaundice. So tell me, what are the causes for the obstructive jaundice? One of you, right? Not necessarily be Binu, so someone else can answer.
It could be gallstones, pancreatic carcinoma.
Okay.
Can you hear me, sir?
So can you just categorize and just right? Can you categorize and just okay?
It could be like obstructing the biliary tree.
So tell me what are the causes for the obstructive jaundice?
Gallstones obstructing the biliary tree, pancreatic head carcinoma.
So there are benign causes and malignant causes. Okay, there are benign causes and malignant causes. Okay, so what are the malignant causes? As he mentioned, Binu mentioned, what are they? Starting from right?
Pancreatic head carcinoma, cholangiocarcinoma, and periampular carcinoma.
Okay, periampullary cancers, duodenal cancers, right? Distal CBD cancers, distal cholangiocarcinoma, CA head of the pancreas. So the cholangiocarcinoma can be distal or hilar. You call it Klatskin tumors. Okay, and what else? So what are the other causes? Malignancies can causing obstructive jaundice. Huh? Any malignancy which causing portahepatis lymphadenopathy. Any malignancy which causing portahepatis lymphadenopathy, right? Okay. Any intra-abdominal cancer which causing portahepatis lymphadenopathy, right? Maybe gastric, whatever, right? Okay, what else? So what are the other cancers? There are some more cancers.
Liver secondaries between caudate and quadrate lobes.
Yes, very good. Liver secondaries in the so that hepatic hilar region, that means quadrate and caudate lobe, segment 4 and segment 1, right? So caudate and quadrate again, if it compress the bile duct, can cause jaundice. Okay, maybe secondary or maybe primary cancers like HCC, hepatocellular cancer, or maybe secondary cancers. Okay, what else? One more cancer.
Mirchi syndrome.
So it's not a cancer, am I? So I'm asking about the cancer, malignancies.
Ampullary carcinoma?
Yes, ampullary, we mentioned those. Periampullary,
Intrahepatic cholangiocarcinoma.
Yes. In what instances intrahepatic cholangiocarcinoma present with obstructive jaundice? ඒක කියනවා නම් ඒකත් එක්ක කියන්න ඕනේ. Otherwise it's wrong, right? Intrahepatic cholangiocarcinoma obstructing both major ducts.
That skin type.
No, so when you consider the cholangiocarcinoma, there are 3 cancers, right? Distal cholangio, hilar cholangiocarcinoma, and intrahepatic cholangiocarcinoma. Distal cholangiocarcinoma and hilar cholangiocarcinoma invariably present with the obstructive jaundice. But intrahepatic cholangiocarcinoma, it can be in the one side, right? If it is in the one side, just the constitutional symptoms like loss of weight, loss of appetite, right? When you check the liver profile, just increase alkaline phosphatase and gamma GT. And when you do the ultrasound scan, some focal dilatation only. If it is confined to the single one side. So, but if obstruct main duct, left and right intrahepatically, so it can cause obstructive jaundice. Okay, so it's a rare presentation. Obstructive jaundice is a rare presentation of intrahepatic cholangiocancer, but still can have. Okay, what else?
So can lymphomas present with obstructive?
Yes, lymphoma, if the lymph node is in the hilar region, if it is compressed the liver hilum, the bile duct, yes, you can present with the obstructive jaundice. One more cancer. So what about the gallbladder cancer?
Metastasis.
Not all the gallbladder cancers, but if the gallbladder cancer, gallbladder, neck, cystic duct, and then it may infiltrate into the spread into the CBD-CHD junction, right? So if it is spread to that area, patient will develop jaundice. Okay, so those are the cancers for the obstructive jaundice. If they ask if patient presented progressive jaundice, obstructive jaundice with loss of weight, loss of appetite, you need to think about the cancers first. Okay, and once you do the investigation, even once you do the Whipples, the specimen say no malignancy, but the impacted gallstones. There may be a situation like that, but most of the time it's cancers. Okay, right. So what are the benign causes for the obstructive jaundice?
So can enlarged lymph nodes of lungs cause obstruction from the metastasis of
obstruction? සෑහෙන ලොකු වෙන්න වෙනවා එහෙම වුණොත් නේ. Okay. නෑ කියන්න බෑ. Right. Okay. ඒක විතරක් ලොකු වෙලා දින්නේ නෑනේ පුතා. Right? තේරුණා? Okay. නෑ. I'm asking, so what are the benign causes for obstructive jaundice? Sorry?
Strictures.
Strictures. Okay. Biliary strictures. So what is the reason for biliary strictures?
Post-op.
Laparoscopic. Yes. So you need to, in this patient come across with the lap coli. So you need to ask about with detail about that thing, right? So especially whether this one is difficult lap coli. So you can get the idea whether you had a drain post-operatively, how many days you were in, any procedures after the lap coli, another procedures after the lap coli, those kind of things you need to ask, right? If patient mentioned that I had the lap coli, right? So this may be a secondary to the biliary stricture, right? Okay, benign biliary stricture, right? Okay, good. What else?
Due to complication of pancreatitis.
Yes, very good. Due to the complication of pancreatitis. So you need to ask about whether have you ever had any pain before, right? In the history, any kind of pancreatic kind of pain, chronic abdominal pain, whether patient had any kind of pain, you need to ask, right? Suggestive of chronic pancreatitis or episode of acute pancreatitis, you need to ask. Okay, so what are the causes for obstructive jaundice in patient with chronic pancreatitis?
Stricture.
Yes, inflammatory stricture. Okay, inflammatory stricture. What else?
Pancreatic pseudocyst.
Pancreatic pseudocyst.
Yes, pancreatic pseudocyst compressing the bile duct. Okay, what else?
Intervention done for the pancreatitis that can cause the
මොකද්ද පුතා? I didn't understand.
we are doing ERCP and procedures for the pancreatitis and the
Right. So these are the things, right? Pancreatic, I mean, chronic inflammatory strictures can cause, it can cause stricturing of the CBD. Other thing is, pancreatic pseudocyst can compress the CBD. And other thing is, the inflammatory mass can compress the CBD. Those are the reasons for, and other thing, of course, those are the basic three things to develop the obstructive jaundice in chronic pancreatitis. So don't forget to ask about the previous history of chronic pancreatitis. Okay. What else? So what are the other benign causes for the obstructive jaundice?
Gallstone.
Yes, stones. Don't forget to mention stone. Stone come first, right? Stone. So how do you differentiate stone presentation with the malignant kind of things presenting?
The intermittent jaundice with
Yes,
stones.
in case of stones, it is kind of an intermittence, right? And associated with biliary kind of abdominal pain. That means biliary colic kind of pain, right? Okay. So those, and it's usually associated with, most of the time it's associated with fever with chills and rigors, kind of a cholangitis features, right? But malignancy, it's less likely. You can't say no, but less likely. In benign, I mean, in the stones, it is more likely. Right. Okay. What else?
Primary sclerosing cholangitis in a patient with IBD.
Sclerosing cholangitis. Very good. Okay. In patient with inflammatory bowel disease. Right. Okay.
Mirzi syndrome.
Yes. In patient with Mirzi syndrome. Right. Mirzi syndrome. So what is Mirzi syndrome?
It's when the gallstone is impacted in the of the gallbladder, so it compresses the common bowel.
Yes. So this happened in large patient with larger stones in the gallbladder, and it's stuck in the Hartmann's pouch, and it's compressing against the CHD, common hepatic duct. And initially it is compression, but it may be ended up with fistulation, right? Okay, so those patients can present with the jaundice. Okay, good. What else?
Parasitic infection, like
yes, yes, parasitic, liver flukes, and the other thing is Ascaris lumbricoides, right? The Binu asked about the foreign travel. I think he must have asked about that thing, eh?
Yes, Chinese liver fluke.
Yeah, okay. African and Chinese, Japanese, right? Okay, any foreign travel, right? Okay, right. What else? How much putara dinne?
compression by mucus.
Huh?
Compression, external compression by mucus.
Mucocele licking compression licking, yes, maybe. Right. So basically, those are the things. So what is the other thing? Primary biliary cirrhosis, right? So that also primary biliary cirrhosis, right? Right. So those basically the primary biliary cirrhosis and sclerosing cholangitis basically managed medically, right? Okay. Other things are surgical things. Okay. Right. Those are the causes. So you need to, when you get the history, you need to ask at least, I mean, you need to get the basic things. Don't forget to ask about the basic other associations like T color urine, itching, pale stools, loss of weight, loss of appetite, fever with chills and rigors, bleeding diatheses, those kind of things. You should not miss. So if there are any Rajarata people, they may know that when I discuss the history, there's a format, right? In the history of presenting complaint, right? The first thing, you need to analyze the symptoms, right? You need to analyze the symptoms like jaundice, whether it is duration, progression, whether it is continuous or not, like that. And you need to ask about the associated symptoms. And with those two, you can come to you can narrow down your differential diagnosis above I mentioned, right? Narrow down the differential diagnosis. And with those differential diagnoses, you can get so what is the next thing? You need to ask about the etiology, right? Okay, etiology, there are personal history. කියන්නේ මට වෙච්ච දේවල් මොනවා හරි කලින් ලැප් පොල් එකක් කරලා දිනවද කලින් කැන්සර් එකක් තිබිලා දිනවද those kind of things, right? And family history and the habits, right? Again, alcohol, smoking, maybe beetle chewing in certain situation, not relevant to this one. And other thing is, fourth line is complications, local spread of a malignancy, distal spread of a malignancy, and complication not directly related with the cancer spread, but in case of jaundice patient, right? Jaundice can cause vitamin D deficiency and causing vitamin K deficiency and causing the bleeding diathesis. You need to ask about the bleeding diathesis and about the hepatorenal syndromes, right? About the liver failure, those things, right? Those kind of things with the complications. Next important thing is you need to ask about what has done up to now. So you should not miss that component in your history. What has done up to now? I think Binu get the he's successful with that, I think, right? So he tried to get what has done up to now, right? So hari පටන් ගත්ත දවස් ඉඳන් කියන්න like that. So you need to get the summary of that thing at least, right? So what are the investigation? So what are the procedures? Maybe a neoadjuvant treatment, right? Maybe surgical procedure, maybe endoscopy, maybe ERCP, those kind of things, right? So you need to get that information. That is must. If you miss that, so you just like discussing the simple history, right? So but if you get the what has done up to now, imagine that in this patient probably initially present with obstructive jaundice, had the initial ultrasound scan and the CT scan, and had the ERCP, right? Patient may come again to the ward for maybe assessment for to assess the fitness, maybe, right? Those kind of things, right? But in this patient, so that necessary investigation has been done. Then when you summarize the patient, you can mention that this is 58-year-old male patient, initially present with features of obstructive jaundice, and investigate, and probably he has had with the ultrasound and the CT, and probably he has had ERCP, and now symptom relief, and patient admitted for another kind of procedure, the assessment, right? And you can include risk factors like patient is smoker and consuming alcohol, history of alcohol consumer, and having a family history, kind of things. And what else patient got, right? Then right, yes, then the patient's family support, right? And finally the examination findings. You need to summarize that like that. Then the examiner who are going to discuss know that this patient, this candidate got the comprehensive history, right? If they ask about forget about the things has done up to now, you just tell me what are the things patient, so what do you need to do? So you know the sequence patient already had, so you can mention those things. Or else he may ask the things you need to do from that point onwards, right? So you just jump a few steps ahead, right? Okay, right. The rest of the history is basically the just completion of the other things like comorbidities, fitness assessment, right? Past surgical history, not relevant to these things in the history. The lab quality should come first, right? Okay, and those kind of things. Allergies, don't forget to ask the allergies, right? Family history, of course, you need to ask in the history of presenting complaint. The rest of the things you need to ask, right? And the just to complete the rest of the things, right? If you get that kind of history, that's comprehensive, and you'll get good mark. In the examination also, basic investigations, basic examination, jaundice, fallow, cervical lymphadenopathy, bilateral ankle edema, features of chronic liver failure, those kind of things. And the abdominal examination, you need to mention about the hepatomegaly, you need to mention about the palpable gallbladder if the patient hasn't had any lab coli before, right? And free fluid, splenomegaly, those kind of things, right? And the rest of the examination if you have time, right? Then you need to make good summary and present it there in the next station, and then proceed with that, right? Okay. Binu, can you go through the chat and can you ask the question? Do you have any questions?
So I have a question regarding the previous pain in the. So how can we differentiate the pain in cholelithiasis? Is it like is it reduced pain because of the reduced concentration of smooth muscles, or?
No. So the biliary colic pain. So you need to remember that there are enough patients who are having bile duct stone but never get any pain, right? Maybe some pain, you do the investigation, you find out that there is stone. And there are some group of patients, they are having typical history of biliary colic, like sudden onset severe pain in the right upper abdomen radiating to the scapular region associated with nausea and vomiting, and it settled within 20 to 30 minutes. Sometimes when you go to the hospital, when patient goes to the hospital, at the time you doctor see the patient, the pain settle, right? That is the typical history, but it can change. The duration may be vary, right? If it is exceeded, so it will become acute cholecystitis. Initially, the chemical kind of cholecystitis, and then, right? And the pain resolved because the stone fall back, right? That pain is because of the squeezing of the gallbladder. Squeezing of the gallbladder, right? Squeeze vela natara karahan passe either the stone can fall down to the gallbladder again, or passing through the cystic duct, or it can stuck in the cystic duct. Okay, so if it is passing through the CBD, so patient won't get pain again, right? Patient may have some pain, but usually not severe like that. And when it stuck there in the ampulla, right? So patient develop jaundice. Okay.
Yes, sir. Thank you.
Okay. What is the other question?
So in the chat box, we have Fernando asking, what is the imaging modality to confirm pancreatic head cancer?
Yes, it is obviously the CT, right? So with the CT, with a CCT, chest, abdomen, and pelvis, so you can get the pancreatic protocol, right? So if you suspect that lesion is in the pancreatic region, you can get the pancreatic protocol with that CT. So you can get you can get the diagnosis of C head of the pancreas. If you have any doubt, you can do the US and then confirm it with the biopsy, right?
The same person asked, what is the initial imaging modality of choice of pancreatic head cancers?
So basically, starting with the ultrasound scan, right? Imaging modality, ultrasound scan, and then of course you can do the CT scan, right? So you can consider the MRCP in this patient if you have any doubt of the lesion extension towards the along the bile duct. Okay, so otherwise CT is enough.
Same person asked the treatment options for operable and non-operable pancreatic head cancer.
Yes, treatment options for operable, the Whipple's procedure, right? Whipple's procedure. I think we described that thing. And non-operable means, so basically the 80% of the patient with C head of the pancreas, so basically the ended up with palliative care, right? Just to reach maybe 20-25% of patient, we can do the curative intent surgery, that is Whipple's. And for that one, basically we need to palliate the obstructive jaundice. That is the main problem patient with CA head of the pancreas. Okay, so you can do the best thing would be RCP and stenting, either plastic stent or metal stent, depending on the life expectancy of the patient. If that fails, you can do the external biliary drainage and you can internalize the things so that you can do the anterograde stenting. Okay, you can try anterograde stenting if the ERCP fails. Or else, if the life expectancy is much higher, so you can do the bypass surgeries. So, but now basically the less invasive things are getting popularized than doing the surgeries. Okay, right.
So
when do you? Yes, okay. Yes, you can ask.
Management steps of pancreatic head cancer.
Management step of pancreatic head cancer. So
yes,
you need to confirm your diagnosis, right? You need to confirm your diagnosis with those investigation, and you need to discuss those patients in the MDT and decide whether this is operable or not. If it is operable, we need to see the fitness for the fitness of the patient, optimize. If patient is having high bilirubin, you may need to do the early decompression like ERCP or maybe EBD, and you need to get a reasonable low level of bilirubin. And then once patient is getting better, you can go ahead with the definitive surgery Whipple's procedure. Okay, and for the patient who are not operable because of the METs or because of the local invasion, you may consider neoadjuvant treatment, that basically the chemo, and you reassess the patient. You may consider resection again, and if that also fails, or if it's beyond the resectability, so you need to palliate. Basically, the palliation, one thing is obstructive jaundice, that is the main thing. So you need to stent, I mentioned earlier. And And if patient is having a gastric outlet obstruction, you may consider the bypass surgery, gastrojejunostomy, palliative gastrojejunostomy, and for the pain, maybe according to the pain ladder and the other modalities of pain management.
So, what are the indications for stenting of the bile duct in a patient who present with progressive jaundice?
What are the indications for stenting?
Yes.
Right. So progressive jaundice means, so I mean, there are no hard and fast rule. I mean, if patient present with less level of bilirubin and if patient is operable, so you can consider Whipple's procedure directly. Right? I earlier also mentioned that if patient's bilirubin level is high, like 200, 250, 300 like that, so you need to decompress that thing. So otherwise, patient's outcome will be poor, right? So because of that reason, either you do ERCP or EBD with the anterograde stenting, right? So you need to nutritionally optimize and then do the surgery. Okay, the ERCP the indication is if you think that it will take some time to get him to the theater, and at the present bilirubin level also high, you need to consider stenting. Okay.
So, are there steps taken before the major surgery like Whipple's according to maybe the enhanced recovery after surgery guideline?
Can you more elaborate on that?
Like for the recovery, are there any steps after the surgery and before the surgery if they're undergoing?
So of course you need to decompress if bilirubin levels are high. So you need to decompress that thing. So it will improve the patient's appetite, sometimes appetite and the liver functions, those kind of things, right? So that is the main thing. Other than that, you need to get the nutritionist opinion, and you need to get the good quality things to enhance the nutrition level of the patient, right? And post-operatively, so I personally don't follow the enhanced guideline for the Whipple's patient. So basically, we just after 3-4 days we start TPN. Then after 10 days only, we 7 to 10 days only, we just make sure that the gastrojejunostomy is working and then start feeding. Right? No any. So I don't follow that thing actually. So I don't know what the. Yeah.
So we
for
have
colorectal, of course, there are, right? Okay.
Another question saying patient present with acute cholangitis.
Acute cholangitis, okay.
And immediate resuscitation done. After that, how would we proceed?
Yeah. So have you heard Tokyo guidelines, Tokyo 18 guidelines for acute cholangitis, right? So basically, basic things are there are mild, moderate, and severe. Severe means septic shock, patient with septic shock, right? Moderate means sepsis. Mild means no features of sepsis. Basic idea is that, right? In Tokyo guidelines, right? In patient with severe and septic shock, probably, so definitely those patients need ICU or SDU care, fluid resuscitation, IV antibiotics. Once patient gets stable, little bit of stability, you can do the decompression. So in this situation, you can't do the ERCP, right? So maybe the ultrasound guided, so that means the kind of a external biliary drainage. Somehow you need to decompress the system. right? So the lesser invasive one is the ultrasound guided puncture, and then they allow to bile drain to the outside, right? External biliary drainage. Okay, but the other two situations, like moderate one, according to Tokyo guideline, moderate one, you consider IV antibiotics, fluid, right? And those kind of things, and then may ERCP within 24 hours. And for the milder group, ideally ERCP within 72 hours with antibiotic, right? Broad spectrum antibiotic and fluid resuscitation, those kind of things. Okay.
So in palliative care, sir, how we treat for the anorexia part? There is significant loss of appetite. So how we can we improve?
Yeah. So certain certain extent, for a certain extent, the anorexia part will disappear with the stenting when you decompress for a certain extent, not the things, and you can biliary decompression improve for a good extent, right? Biliary decompression, and you can give the antiemetics, those kind of stuff, right? Mainstay is biliary decompression.
So there is another question asking other conditions which give rise to double duct sign other than pancreatic head cancer.
Sorry?
Other conditions that give double duct sign other than pancreatic head cancer.
Other condition. So any condition can causing obstruction of those two ducts can cause double duct sign. Main thing is CA head of the pancreas causing both, right? Maybe distal cholangioCA initially in the duct and then compressing most distal part, compressing the pancreatic duct. Those are the things. Other than that, I'm not sure.
So the person has also asked about the endoscopic ultrasound. I think sir discussed about it in the previous question.
Yeah, endoscopic ultrasound. So nowadays, so yeah, here of course in Sri Lanka, to do the endoscopic ultrasound is a bit difficult. So it's available in certain centers only, right? So even in those stations, that scope is not working when we ask, right? Those kind of things. So because of that reason, we won't be able to wait until the US is done, right? So, but so you can with the good imaging report, right? You can go ahead with the surgery without doing the US in Sri Lanka, basically. But in Western countries like in UK and Australia, so there are a lot of litigation problems, right? So there are situation you operate on a benign condition, like a big surgery like people's. You need to avoid that thing. So because of that reason, you just need to get the histological diagnosis, because so you can do the US and core biopsy or maybe FNAC, right?
Sir,
So if you have any diagnostic dilemma, you need to do the US, right? Yes.
Sir, in something like pancreatic head cancer, how do we bring the bilirubin levels down before operating on the patient?
So that's I think we discussed that thing, right? So you just you can do the ERCP. So if that fails, you need to do the external biliary drainage (EBD) and anterograde stenting. Okay.
Yeah, thank you, sir.
Any questions?
So the next question is, what are the conditions which give conditions other than cancer causing progressive jaundice? I think we discussed that one.
Yeah, that's of course in any kind of biliary strictures, right? Maybe benign stricture, secondary to the previous lab, the difficult lab call is bile duct injuries, right? And chronic pancreatitis, the stricturing things, but the pseudocyst can, the jaundice can reduce, but the other pseudocyst and mass, because of the mass compression that reduce, but the other one, inflammatory strictures, it's progressing, those.
And
that's why, so we are not just rely on the clinical things. That's why we do the investigation. Even after the extensive investigation, once we decide doing Whipples, once we do the Whipples, so that's benign pathology sometimes. That can happen, right?
So I will start the questions from the bottom now.
Yeah.
Sir, can we apply Courtier's law for gallstone jaundice in all time?
Courtier's law, actually, what is Courtier's law mean? Right.
It
So
basically it's the opposite of.
What's that?
If
Courtier's
there
law?
is a distended gallbladder, it is unlikely to be the
Unlikely to be
gallstone.
due to gallstones. There are two exceptions in gallstones, right? One thing is simultaneously block the ampulla and the cystic duct together. එකපාරටම හිර වෙනවා. එහෙම වුණාම වෙන්න පුළුවන්. Right? Other thing is Mirici, in case of Mirici syndrome, right? So you can get distended gallbladder with obstructive jaundice. Those are the two exceptions. Okay?
Significance of octreotide infusion post-operatively.
So that will reduce the pancreatic secretions, right? That will reduce the pancreatic secretions. Then so we assume that leaks following pancreatic anastomosis will reduce. Okay. I don't know about the evidence though, right?
Sir, in the past history, you mentioned something suggestive of hepatitis A. Is that
well, this is not
incorporated
this is
presentation?
no this is that just to confuse the things, right? Okay, so that is if it is hepatitis A, it's not relevant, right? So that's long time ago, and it's no any residual things in hepatitis A, right? So that just to just පොඩි මේවා එකක් ගන්නනේ ඔය වගේ patient ලා ඉන්න පුළුවන්, right? මොකද hepatitis හැදිච්ච අය ඉන්න පුළුවන්, right? Because of that is okay.
Sir, can you please explain the place of external biliary drainage and Whipple surgery in perihilar cholangiocarcinoma?
Yeah, I mentioned those things actually. So, so if you fail, so in case of perihilar mean the clad skin tumors, I think, right? Right. In clad skin tumors, usually so the treatment is not the Whipples. In clad skin tumor, the curative treatment is you need to resect most of the time you need to resect the part of the liver with the bile duct, cancer part, bile duct up to the first part of the duodenum, and you need to keep the liver segment you are going to leave with the patient, right? When you decompress, so you need to decompress that the segment we are going to leave. තේරෙනවද? ඒ කියන්නේ අපි ඉතුරු කරන කෑල්ල decompress කරගන්න ඕනේ. හරිද? අනිත් පැත්තට දැම්මොත් මේ liver එක upset යනවා. මේ පැත්ත. හරි. ඒ හින්දා we initially try with the ERCP and try to put a stent to that side, that particular side. If that is successful, that's all right, right? And no need to struggle. So you can put a you can put a tube to that remain the liver segment we are going to keep with the ultrasound guidance, right? Because of that reason, so that is important, right? තේරුණාද කියන එක? තේරුණාද නැද්ද? තේරුණ ඒ කියන්නේ අපි liver එකේ ඉතුරු කරන කෑල්ල decompress කරගන්න ඕනේ. මොකද liver එකේ කෑල්ලක් එක තමයි අපි operation එක කරන්නේ. හරි? Hepatectomy with bile, the right or left hepatectomy with bile duct excision and Roux-en-Y hepaticojejunostomy. That is the surgery we are going to do. එතකොට අපි ඉතුරු කරන liver එකේ කෑල්ල තියෙනවානේ. liver එකේ ඉතුරු වෙලා තියෙන කෑල්ලේ ඒ obstruction එක හින්දා එන back pressure එක අඩු කරගන්න ඕන. හරි ඒක කරගන්න ඒ පැත්ත තමයි decompress කරගන්න ඕන. එතකොට ERCP එකක් කරද්දි සමහර විට ඒ පැත්තට දාගන්න අමාරු වෙන්න පුළුවන්. ඒ වගේ situation එක we can put a EBD to that particular duct. Okay? ඔය වගේ වුණා final වල අහන්න නෑ පුතා.
The next question, can renal cell cancer present with obstructive jaundice?
So if it is spread to lymph node, yes, right? නෑ කියලා කියන්න බෑ. I think වෙන්න පුළුවන් නේ. ඒ කියන්නේ හැබැයි ඉතින් මෙහෙමයි. So what are the causes for obstructive jaundice කියලා හැවුවොත් එකපාරට renal cell cancer කියන්න එපායි. Please remember that thing. හරි?
So next question, can we go for ERCP, MRCP straight after the ultrasound scan?
MRCP එකක් නම් අපි CT එකකින් පස්සේ තමයි සාමාන්‍ය කරන්නේ. මොකද බේසික්ම එක තමයි CT කරන එක. You just do the CT scan and see. CT එකේ අපි කියමුකෝ ඊළඟට MRCP එක පැත්තට යන්නේ අපි we just need to see the duct, involvement of the duct. Imagine that clot skin එකක් තියෙනවා, it spread to the both side of the duct. It is inoperable. No point of doing the MRCP in that situation. And there are patients with liver mets, no point of doing MRCP, right? Because of that reason, you do the CCT first and then do the MRCP. And ERCP, of course, just after ultrasound, as I mentioned earlier, you get with the ultrasound scan, patient is having obstructive jaundice and CBD is dilated up to the distal part and having a significant the ultrasound feature suggestive of a metastasis. In that case, you consider the ERCP without wasting the resources. Okay?
So the next question is place for chemotherapy and radiotherapy.
Chemotherapy and radiotherapy, the surgical resection is the best. But we can consider neoadjuvant treatment to down in case of marginal resectability cases. So, but it's not curative. We can't get like curative radiotherapy, curative chemotherapy, like in some other cancers. Okay?
So the next question is, what are the things we need to consider in palliation?
Basic thing is the obstructive jaundice, gastric outlet obstruction, nausea, those kind of things, and pain. And the nutritional status, those are the things.
And the same person asked, could you please explain about Whipple's procedure and pylorus preserving lymphadenectomy?
Pylorus preserving Whipple's or the lymphadenectomy. So Whipple's I mentioned earlier, right? You just excise. So you have the cancer part. With the cancer part, you remove the part of the stomach, entire D1, D2, D3, D4 with the part of the jejunum and the bile duct. So if gallbladder is there, we need to get the gallbladder as well, right? We need to anastomose to the hepatic ducts, right? And you just remove that thing. Then to the remaining part, you just first do the pancreaticojejunostomy. Secondly, you do the hepaticojejunostomy, and last you do the gastrojejunostomy to the remaining jejunal loop. Okay. So that is the basic things about the Vipals. So it is usually it will take 5 to 8 hours depending on the complexity, right?
So the person has also asked about complications after surgery and follow-up.
Yeah, basic complications are we do 3 anesthesia. One thing during the surgery is the main thing is the bleeding, right? You are dealing with the very critical structures like portal vein, hepatic artery, right? The superior mesenteric artery, right? So we are dealing with those kind of vascular structures, and so if you mess with those things, you ended up with disaster, right? The number one intraoperative thing is bleeding. Even post-operative period, bleeding can happen because so we tie the gastroduodenal artery. So ligate කරපු එකක් මෙයා වෙන්න පුළුවන්. Those kind of things can happen. And secondary, because of the other complication is leaking of those 3 anastomos, right? And the most what we are worrying, the main worry is pancreatic leak, right? So it's very difficult to manage, and if you get that thing, patient need to stay longer period. So we can't go in and do the reanastomosis. Okay, we can't go in and do the reanastomosis. So other thing, you just need to wait. We need to give good washout and then keep couple of drains, and you need to wait, right? Checking the drain output like that. Okay. Another thing is maybe biliary drainage, biliary leak, bile leak. Another thing is gastrogeg leak, and you can present with they complicate with the upper GI bleeding, right? So last time we had a patient with Vipals, and patient got massive upper GI bleeding secondary to the stapler line leaking. Stapler anastomos එකකින් following day it's open up and we had to reopen and redo the anastomos, right? ඒ වගේ දේවල් එන්න පුළුවන්. يعني bleeding එන්න පුළුවන්. Anastomotic leak. Other thing is relevant to any other major surgeries like surgical site infection, chest infection, those kind of things. Okay. හරිද?
Yes, sir. That's all the question.
Okay. That's all.
Yes,
Okay.
sir.
Thank you very much, Anuradha. Actually, it was a very comprehensive discussion. I think that you had a very good opportunity because he's an expert in this subject. Therefore, you had a lot of questions. He answered all questions. Thank you very much for accepting our request and participation. Your kind acceptance as well as your very thorough discussion about this subject. Then day after tomorrow, tomorrow we don't have a webinar. Day after tomorrow there will be a webinar by Dr. Ranga Vikramarachi, GU surgeon from KDU. We hope that you can join and get some knowledge from GU surgery because he's going to discuss about hematuria. Then until that, say goodbye, good night actually for all of you. Thank you, Anuradha, again. Okay.
Thank you very much for the opportunity. Right. Okay. Good night.
Sir, good night.
Good night,
Thank
sir.
you, Vinay. Okay. Good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, sir.